Where is the uh, right modified BT shunt anastomose to the pulmonary artery?
Sir, mm,
It has to be done as proximal to the bifurcation. So when you take down, you tape the SVC and retract the SVC after opening the pericardium. That's the first thing.
yes, sir.
Then aorta is retracted to the. Then you dissect. If done properly, you can easily get it because it's done in between the area. Whereas a left modified BT shunt is approached extra pericardially and extra pleurally.
Yes, sir.
So it's much deeper, and very often the danger is a phrenic nerve and the recurrent laryngeal nerve. On the right side, it is not that easier to take down after opening the pericardium first. In the left one, you open the pericardium, stay sutures, pull it. Then you dissect extra pericardially.
Yes,
Okay, all right. You go proceed. Yeah.
yes.
You,
Uh, the approach can be sternotomy versus thoracotomy shunt. Sternotomy shunt usually on innominate artery, while thoracotomy can be usually put on subclavian artery. Sternotomy shunt is more medial and shorter, so higher flow. We can use one smaller shunt in case of sternotomy. Thoracotomy shunt longer and more peripheral, so lesser flow, can use larger diameter. The sizing of shunt based on base. So if the pediatric age patient is less than 3 kg, the shunt size is 3.5 mm. 3 to 5 kg, the shunt size is 4 mm. More than 5 kg, the shunt is 5 mm. So,
is it always done to the under aspect of subclavian artery?
no, sir. You can use,
Subclavian, sometimes encroaching on the innominate, so it comes under the on the under aspect of innominate and subclavian
yes,
artery. This is in a left aortic arch when you do median sternotomy and shunt.
yes, sir.
So in
Okay.
median sternotomy, it is almost always from the innominate only, sir.
Yeah,
That
yeah,
because the subclavian takes is like the origin is almost away from our
yeah,
sternotomy side.
yeah,
It
yeah,
may be
yeah.
difficult to get the anastomosis there.
Mm.
So yes, yes, sir.
So,
So probably you can list out advantages and disadvantages of each approach.
Yeah.
Advantages of sternotomy, disadvantages of sternotomy, advantages of thoracotomy, disadvantages of thoracotomy.
okay, sir.
Because
Yeah.
there are surgeons who do thoracotomy even now. I mean, even here in NH, and there
Yeah.
are
So,
some surgeons even in big centers who do always midline shunts.
Yeah.
So
We are all
neither is correct. Yes.
we are all Srikishna and all, we are all basically thoracic surgeons. So we used to prefer to open the
Thoracotomy.
thoracotomy and do the
Yes,
shunt.
sir. Yes, yes, sir. Yes, sir.
And our other argument is because this for second operation, there's no adhesion to the median sternotomy. So
Yes.
of course now cardiac surgeons are expert. Second or third operation, they do.
Yes.
You should be scared those time. Okay, all right.
The
Yes.
only time cardiac surgeons did thoracotomy was for BT shunt and closed mitral commissurotomy.
yes,
Commissurotomy. Yes.
Both those things are gone now.
Okay. Huh?
yes, sir. The other shunt is water shunt. in the water shunt will be an osmosis between ascending aorta to the right pulmonary artery, the side to side ascent. It provides large pulmonary blood flow. There is a high risk of pulmonary overcirculation, pulmonary artery distortion, and
Your slide is not moving. You're still on modified BT shot.
is it
Yeah.
now? Now, sir?
Yeah, but the picture is not Waterston Center.
It's saying Waterston Shunt 1962.
Yes. What?
That's the slide.
That's not
Yes,
the
sir.
slide. That's not the.
No,
This
because
is the draft.
I mean the
Yeah,
waters
Yeah, yeah,
the picture is showing a modified shunt.
shunt. Yeah, because it has to be from the ascending aorta.
yes, sir.
You goofed when you did the slide, I think. Okay, wrong picture.
It's, so,
There are two stands,
yes, sir.
Waterston stand and Waterston Cooley stand.
Yes,
What's
sir.
the essential difference between a Waterston and a Cooley stand? Both around 1966 or sometime they did. I mean, I think Waterston did first and Cooley. What essential difference between these two?
Sir, water shunt is through ascending aorta to right pulmonary artery, and
Both are ascending order to right pulmonary artery.
this is water shunt is direct side to side anastomosis, but water shunt pulley shunt we use interposition graft like
No,
PG.
No,
no,
no, no,
no,
no,
no,
no.
no, 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 no. Interposition graft later came and then nobody does it nowadays. Nobody does water shunt also.
Okay, I'll give you a clue. One is intrapericardial, one is extrapericardial.
Uh, uh,
Which is which?
this water shunt pulley is extra pericardial, sir.
The way around.
The essential difference is that the original water shunt is done to right posterolateral or lateral thoracotomy. You enter the pleura first, then dissect out the right pulmonary artery as much medial as possible. At that stage, you have to enter the pericardium. Then you dissect out little more. Then you get the undersurface of the aorta. Then put a Cooley clamp, including the uh, right pulmonary artery and the bit of the posterior part of the aorta. The most important thing is that it should be done directly on the most posterior part of the aorta.
Okay, sir.
Because if you don't do that, it kinks, there'll be preferential flow. So it should be exactly in the posterior part of the aorta, and anastomosis should be small, less than 5 millimeter actually, because the greatest danger of either POTS or disease, you can easily overdo the shunt actually. Cooley do it through does it through an anterolateral thoracotomy. The first thing is open the pericardium, and then you put a stay suture. This is what we used to do. Put a stay suture on the right uh, uh, appendage, pull it down. Then you dissect out the right pulmonary artery and the aorta. There also, you use a single clamp, a distal clamp or snares are used on the branches of the pulmonary artery, and you use a single Cooley clamp.
Okay, sir.
Posterior on the pulmonary artery and get a little bit of the aorta also and make an opening in that and make anastomosis. And you have to be exactly on the posterior part of the aorta. The greatest danger, the cooling clamp used to have marking 5 millimeter, so that very often you overdo it actually. POTS is not done at all. What is POTS now? What is it done
Yeah,
in
the
Narayana?
indication.
Huh?
No, I think in Narayan at least we're not doing POTS, sir, but there are some few centers who are doing surgical and interventional POTS. So I think there is just one, maybe one indication
That's
for
not
POTS,
for
right?
congenital. That's not for congenital. Nobody does
Yes,
POT stand for congenital. It's for primary pulmonary
pulmonary
hypertension or
hypertension, sir.
idiopathic pulmonary hypertension.
Hypertension.
Some cardiologists do it by cath. I don't know how they do it,
Yes,
how dangerous it is. But in Narayana Hridayalaya, they have done a few cases by using a graft between the
yes,
main pulmonary artery and the left pulmonary artery and the
artery and
descending towards
the descending
aorta,
aorta. Yes,
so that the right ventricular pressure will not go suprasystemic, So, and also there'll be reverse shunting of the blue blood. That blue blood goes to the legs, not to the brain. That is, I think they have done a few cases. I don't know the results. So, other actually don't mention pots and water stand
Okay.
as a palliative measure these days.
Okay, sir.
Okay. All right.
You can only
so
mention them as historical operations.
Yeah. And pots is one of the most difficult things to take down.
yes.
Okay.
So there's
Okay.
another modification. It's called the lax shunt, sir. Lax
And
shunt, or
lax
yes,
castaneda. I used to do that actually now.
yes, sir, yes, sir. So
Because
it's
in the left aortic arch, the left subclavian is so good, so long.
yes, yes, sir.
She says, what is the lax castaneda modification of on shunt done on the ipsilateral side?
Okay.
What's the problem if you try to do a modified shunt on the side of the not modified, a classical uh, BT shunt on the aortic arch side? Because it arises from the top. If you bring it down, it kinks there. Whereas if
Kings
you
there.
do opposite to the aortic arch, that subclavian arises from the innominate. So it makes a smooth curve without kinking. Whereas if you do on the aortic side, it kinks there. So it doesn't work. Then what is, as Sujit asked, what is a lax castaneda shunt?
So, this RVOT reconstruction.
No, no. We are saying about the uh, classical
Sir.
BT shunt.
Okay. That side to side anastomosis between aorta and main pulmonary artery.
No, no.
No,
It's a with a subclavian origin arterioplasty. That means you put a side clamp, including the subclavian artery and part of the arch. Then you make an incision at the root of the subclavian artery onto the aorta. Be an incision, and then you suture it down. So that what you have done is now you have done a subclavian arterioplasty so that the subclavian artery is not arising now from the top of the aorta, but it's also arising from the side of the aorta. You
Yes.
understand what I say?
Yes. Yes, sir.
You make a incision on few millimeters onto the subclavian artery, few millimeters onto the aorta, and fold it down and make anastomosis so that the subclavian now arises partly from the side of the aorta, so it cannot kink. That's a modification. I don't know, Sujit, whether anybody does it or not, but it
no, no.
used to be
It's
a good
just
operation, I thought.
yes. No, no. This is a good operation, sir. But no one. I've not seen anyone doing it
Yeah.
of late, sir. But there is another little recent. I think it's described in maybe 2014-15, sir. This is one other shunt called Eves Dudicum shunt, sir. Eves Dudicum is
Oh,
one of the surgeons who was. I'll just spell out the name. It's Yves Eves Dudicum.
yeah.
DUDE. AEM. So he was in Royal Children's Melbourne, sir. So he was actually a French surgeon who's worked in Royal Children's, and he has described a shunt where uh, they do a they take a graft, and it's done through midline sternotomy. Suppose there is TOF with pulmonary atresia, and we have to establish flow into the pulmonary artery. So they make a small opening onto the MPA, and then they anastomose the graft end on to the MPA. And
Okay.
now, once that is done, they bring the graft anteriorly over the aorta and see where the graft falls on the aorta, sir. And then where the graft falls on the aorta, exactly there they do a side to side anastomosis of the graft with the aorta. And once the side to side anastomosis is done, the end of the graft is clipped.
Mm.
The end of the graft. So it's like a midline shunt only, but it's like a slight modification, sir. This is called
Yeah.
Dudicam shunt. It's easier to
Why
take down
why
because
do a side to side when you can do end to side on the aorta?
because if you do end to side, it's going to overflow, sir. But you can control the size of the side opening onto the aorta, sir. Because you're using the ascending aorta, and then the pressures are very high. So one way to control the over shunting is to see how much exactly the size. You cut out that much only on the side of the graft and make a small opening. So even if it's like even if it's small, it is going to flow well because it is coming off directly from the aorta.
This
That
is
used to
like a
be
modification of the me shunt.
Yes, sir, correct. So it's a modification of the me shunt, sir, of a Melbourne shunt.
me shunt is done mainly because I know me very well. Uh,
Yes, sir.
in a pulmonary valvular atresia, the
Yes.
main pulmonary artery is taken down and then it's lower end is sutured, the proximal end, and the end of the main pulmonary artery, because it's only pulmonary valvular atresia. You cannot
Yes, sir.
do it when pulmonary arteries are treating. And then it's
Yes, sir.
anastomose end to side of the aorta.
Yes, sir.
We
Yes,
used
sir.
to do some shunt. I didn't know that. I never knew because I used to go to uh, Royal Melbourne every 3 5 years actually.
Yes.
Because
Yes, sir.
that time when I went, I never heard this guy's name. I saw
Yes, sir.
only Shunji Sano, who introduced,
Yes.
he was
Yes,
working
sir.
under Roger Me, who
Yes.
introduced Sano Shan. I never heard of this guy. But
If yes,
I
sir.
heard main pulmonary artery to the
Yes, sir.
aorta as a
Yes.
little U-shaped. Then that
Yes, sir.
U-shaped, that's a very inconvenient thing. That's why they introduced main pulmonary artery, end of the graft to the main pulmonary artery, and
Yes, sir.
the other end is sutured it off. And as Sujit said, you make an incision on that graft and make a side to side anastomosis
Right.
to the aorta.
Yes.
That's all.
Yes,
Yeah,
sir.
yeah.
Yes. Yes, sir.
Okay.
Yes.
Finally, of all these things, what will you do? It is. What is it?
So yeah, so I think it's very important to know when you'll go. I mean, the
Yeah,
advantages and disadvantages of both thoracotomy and sternotomy. If
yeah,
you don't have it, then I'll just say it so that you know you.
Yes, sir. Yes, sir.
So in thoracotomy, the good thing is that you don't need bypass. Okay, I
yeah,
mean that is one thing, and second thing is when you're going by a thoracotomy, uh, your your intrapericardial adhesions are going to be less because shunt is not the final operation.
yeah, yeah,
So, so that is the advantage of a thoracotomy shunt. But the disadvantages of a the main disadvantage is, suppose while doing the shunt, the anesthetist is not really up to it, or if the child you are clamping the PA
yeah,
in a shunt
yeah,
in a child who is spelling, okay,
yeah,
so, and if the child goes into a very bad spell and somehow they're not able to manage it, there is no way for you to go on bypass.
yeah, yeah.
It's
That's true.
it's very difficult for you to go on bypass. Okay, so that is a downside of the thoracotomy shunt. And
Yeah, yeah,
sometimes what happens is, if you're doing thoracotomy shunt for the first time, or if you're not very well versed with thoracotomy shunt, the graft onto the PA on the branch PA lies very peripherally, and that may cause peripheral stenosis, peripheral distortion of the PA. So even in a thoracotomy, we try and do it as proximally on the PA as possible so that flow goes into both the branch PAs. But if the dissection is not proper and if it's done very peripherally, like onto the hilum of the either the RPA or LPA, that causes very bad distortion of the uh, peripheral branch PAs. So these are the advantages and the disadvantages of the thoracotomy. But
Yes, sir.
when you're going midline, the main disadvantage I'll tell you first because there is only one. The main disadvantage is that the next surgery is going to be a redo.
Yeah.
Okay, like sir said, I mean, at one maybe at redo was a problem, but now the redo is no more a problem
Yeah.
because if you've drowned yourself in congenital heart surgery, you're day in day out, you're doing every other case is a redo. Okay, out of 10 cases, at least 7 8 are redo because we don't. I mean, that's how it is. We've done cases in the past and we have to revise the cases. So the main problem with the midline midline shunt is that it's like a redo. You have to go in like a redo. Okay,
Yes, sir.
but and the other disadvantage for a midline shunt is, suppose you put in a bigger size graft, there is more chances of over shunting in the mid because you are using the aorta or one of the uh, branches of the aorta for proximal supply. Okay,
Yes,
so
sir.
that is the one other disadvantage of a midline shunt. Okay,
Yes, sir.
so disadvantage, sorry, and
Yes,
the main advantage is while doing a shunt, if there's any problem, you can quickly go on bypass
Yeah.
okay, sir.
because you
Because
have everything. Yes,
yeah, because when we used to do the shunt from the left side, one of the
yes, sir.
things we used to insist that you got everything ready, then just clamp the pulmonary artery for
Correct.
about
Yes.
a few minutes,
3 minutes. See how it
and
holding.
see,
How it's holding. Yes.
and before that, the anesthetist gives 100% oxygen. Then, after test climbing, you release again. Then you get ready for because once you open the pulmonary artery, you're nowhere. As he said,
You're nowhere.
you can have
Yes,
no
sir.
control. You have no
Yes.
control.
And that is the other reason why we go opposite the side of the arch because hoping that there is some PDA on the side of the arch. Suppose there's a
Yeah,
left arch,
sure.
there's a
You don't
left-sided
want.
PDA, so there is
Yeah,
some trickle flow onto the PAs. So while you're doing a right-sided BT shunt, the left PDA is somewhat flowing and keeping the circulation going because you don't know how much time you're going to take to make the anastomosis. It's a small
mhm.
graft also. Okay, so multiple factors. So that's the thing.
Now,
Well,
other important feature was you do the subclavian anastomosis first and then clamp the PA, so that
yeah,
as you release the
Yes, sir. Yes, sir.
clamp,
Correct.
it
It's
flows
always
it
that, sir.
flows immediately.
Immediately, yes, sir, yes, sir. So the subclavian, the arterial end is done first, the inflow, and then once you clamp the PA, you quickly finish the anastomosis and release the clamp, so that there is no further delay.
it's true on the right side because the
Yes,
right pulmonary artery divides into the upper lobe branch. So I've
very early.
heard that
Yes,
even the great Cooley has done anastomosis to the upper lobe branch of the right pulmonary artery. So that can be
okay.
done.
Yes, sir. Yes, sir. Correct. And also the other advantage with the midline shunt is like one is you can go on bypass. Suppose there
Yeah,
is a confluence stenosis. Suppose
yeah,
there's a stenosis where between the RPA and LPA. There
yeah.
is no way to take care of this in a thoracotomy. Whereas
No,
in a midline shunt, you can actually midline stenotomy, you can do some kind of a plasty there. Of course, you have to go on bypass for that. You can do some kind of a plasty to take care to see that the shunt flows into both the branch PS. Otherwise, there'll be preferential flow only to one of the branch PS when you do a shunt. Suppose you do a RPA to innominate artery shunt, and there is a confluence stenosis. The stenosis just before the takeoff of the RPA, all your flow is going to go only to the right side. So,
Yes, sir.
so in a midline shunt, those things can be done.
yeah. There's a
So,
preference that for 60% goes one side, and I think okay,
yes,
something
correct.
like that.
Yes, sir. Yes, sir. Yes, sir.
Okay, sir.
So finally, what will you do? It has to be according to the occasion. You do that. What you should.
Sir.
So it depends on your expertise. It depends on your the way where you're working. Are you in a quaternary center? Are you in a primary center? The kind of help you have at the head end, and
Yeah,
how is your management going to be in the post-operative ICU? It's multiple things actually.
Yes, sir.
So, and taking everything, and also your seniority, and is there anyone to help you out, bail you out in case of, problems? So, so consider everything, and then you'll have to answer this question in the exam when they ask you.
Okay,
Yeah.
okay, sir.
Because Waterston and pots can be easily overdone. Those
Right.
days we used to say the subclavian, because subclavian origin and that area it is limited, so you cannot overdo. But that's not true.
Yes,
Even
sir.
even the modified British shands can be easily overdone, And I think Rajesh, who was here from
Yes.
All
Yes,
India
sir.
Institute,
Yes. Yes.
uh, uh, even an BT shunt, you
Yes.
said
Yes, sir.
3.5, but I read in a neonates and all 3 millimeter. But if
Yes, sir. Yes.
you have to exactly size it, if not, you can even oversize uh,
Correct, sir.
modified
Yes.
BT shunt also,
Shunt.
So
Yes.
you used to
Yes.
try to reduce it by little clipping and all,
Clipping
such
and
a thing.
everything. Yes. Yes. Correct. Correct. Yes,
So,
sir. Yes. So that brings us to the next very very important questions. I don't know how important it is in our setup right now.
yeah,
How do you manage a shunt post-operatively? Because that is a big headache. How do you? There are two big problems with the shunt. You have over shunting and under shunting.
Yes,
Okay,
sir.
anyone can answer this. How do you manage an over? How do you recognize an over shunting shunt and manage it? How do you recognize shunt block and manage it?
yeah.
Anyone is welcome to answer because it is very important. Doing a shunt is just 50% of the work done. The real work happens in the ICU. Anyone? Jitesh.
Yes. A drop, saturation drop, like the
What are you
shunt block.
describing now? What are you talking
Yes,
about?
sir.
You're talking about shunt block. Okay, okay. Yeah. How
Block,
do how will you
shunt,
recognize a shunt block?
block, sudden desaturation.
Okay, okay. One more, one more important thing.
Shingram, in ICU, metabolic acidosis, lactate going high with
No, 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 no.
shunt murmur being absent.
Okay, so loss of shunt murmur is one. Okay,
Yes, sir.
your saturation drops one more. There's one more thing. Suppose you've done a midline shunt. Okay,
Yes, sir.
and then you see that this one something about the BP, the diastolic. After you do a shunt, your diastolic is slightly low, no, because there is
Yes, sir.
runoff.
Increase. Yes, sir.
Instead of a normal 90 by
Right.
60 pressure, you have like 90 by 40, 90 by
40,
30,
sir.
something like that.
Yes, sir.
Suddenly you'll see that the diastolic has gone up.
Right. Yes, sir.
That means that is an indication that your shunt is blocked.
Yes, sir.
Okay, all this metabolic acidosis, lactic acidosis will not happen because the child was surviving without this, no, without the shunt,
Okay, sir.
even without this. So that is more for your over circulation. So how do you recognize over circulation?
So, one can be low diastolic BP,
Okay, very good. Okay.
pulmonary sign of pulmonary edema like absent.
Very good. Yes. So what are the signs of pulmonary edema? How do you recognize pulmonary edema in the ICU?
Uh, there can
Oh,
be
yeah. Yeah.
increase in with X-ray showing pulmonary pressure, increased crabs.
Yes, yes, exactly. So one thing is when you auscultate, there are going to be more creps. Okay, that means the lungs are wet. Okay. Second thing, you'll see that there are a lot of secretions. Okay,
Yes, sir.
the nurse may have to do multiple times suctioning to maintain the airway. Sometimes the airway pressures also go up because of secretions. So these are all
Yes,
clues towards the fact that your shunt is overflowing. Okay, and one other thing on the ABG, you said something before. That will apply
acid,
here. Your acidosis.
metabolic. Yes,
Why acidosis? Because your lungs are stealing all the blood from the body.
blood. Yes, sir.
Yeah. So most of it's like a PDA. You created a large PDA. In a large PDA, what happens? All your blood flow goes towards the lungs. So much so
Lungs.
that the
Yes,
distal body is now hungry of is not getting perfused well enough.
yes, sir.
Okay. So
Yes,
that causes metabolic acidosis, lactic acidosis. So all this points to afterwards. Okay, so that is how you recognize a shunt thrombosis and a
Overflowing shunt.
or overflowing shunt. Okay, so
Yes.
how do you treat a how do you treat shunt suspected shunt block first, like at the ICU level? Forget about surgical. At the ICU level, how do you treat a shunt block?
We can start 100% of oxygen with the
Okay.
starting early anticoagulation with heparin.
Yeah. So heparin will already be going in a shunt.
Yeah.
Okay. In a shunt, what will happen is heparin, as soon as you reach the ICU, heparin is already on flow. What you can also do is you can give like a extra
Thrombolytic.
bolus
Yeah.
thrombolytic agent, extra bolus dose, and just see if it will flush. It'll flush those early clots. Okay, so that you can do. And then with that, another thing what you can do for a shunt block is try to increase the afterload, try to increase the pressure so that there is more pressure head into the shunt. You can start something like a noradrenaline or something, so that the pressures go up. With increased pressures, the shunt tends to flow better.
Okay, sir.
Okay, and then you get an echo done bedside, point of care echo, see how the shunt flow is. And if none of these maneuvers work, you'll have to take the child back to the OT. Okay? So that is about your suspected shunt thrombosis in brief.
Yes, sir.
Okay.
Yes, sir.
And then how do you treat a overflowing shunt in the ICU?
We can.
Medically first. Medically,
Yes, sir.
how do you treat an overflowing shunt medically?
We can decrease the FiO2.
Okay, good.
Uh, we can increase the PVR.
Yeah, how do you increase the PVRI? Okay, you can decrease FiO2. That is one. Anything else you can increase? You can reduce the rate of respiration, no? You can
Yes, sir.
reduce the rate of
Yes.
respiration.
My,
So by reducing
so
rate of respiration, there is some hypercarbia. It is
hypercapnia.
called, yeah. So there is some amount of permissible hypercarbia. You let the CO2 build 45 to 50, something like 50, 55. So with that, what happens is the PVRI increases. And with the PVRI, with increase in PVRI, your shunt flow will reduce. Okay. So first you play around with the ventilator settings. Okay. Second thing, you give some diuretics so that the lungs become more dry. Okay, and then if the diastolics are very low, you'll have one thing what you can do is you can give some blood to increase the hematocrit and increase the diastolic pressures.
Okay, sir.
Okay, so and also try to peripherally warm the child so that the flow improves to the distal body. Okay, so with all these things you try and somehow manage and see if the hemodynamics settle and the lactate settles.
And now Sujit will know that Parvati Iyer has told me she can manage everything by relative manipulation of the systemic vascular resistance and the
Yes, sir.
pulmonary
Yes.
vascular resistance.
That's
It's a classic essay.
yes, sir. Yes, sir. Yes, yes, sir. So, I mean, it's a luxury that we have a large ICU, sir, but it's also a
Yeah.
kind of a drawback that these people don't get to do all that. So, I mean, ICU management is, I think, as
Yeah.
important as operating. I mean,
Yeah.
that is how all of us have been trained, at least. So, okay. So, if nothing else works, you'll have to take the child back to the OT.
Yeah.
You can do one of two things. One is you can try and clip it sideways along the length to
Okay.
to reduce the circulating diameter, the lumen of the
Okay.
shunt.
Okay, sir.
Okay, and then that is one thing. And then if that also doesn't work, I mean, because that tends to sometimes create very turbulent flow, and more turbulent the flow, there is more chance of thrombosis.
Okay, sir.
Sometimes, if that doesn't work, you'll have to redo that shunt again. You'll have to take it down and do another, put a smaller shunt.
Okay.
Any questions about the shunts? Otherwise, go to the transcatheter intervention. Right?
Yeah.
So,
Yeah.
transcatheter intervention in tetralogy failure. So balloon dilatation of pulmonary stenosis, balloon dilatation or ductal stenting, balloon dilatation of peripheral pulmonary artery stenosis with or without stenting, stenting of RVOT for infundibular stenosis by balloon expandable stents, transcatheter pulmonary valve replacement.
Don't go. Just show me. That's
Yes,
right.
yes, sir.
Transcatheter balloon dilatation, I don't think will do anything because isolated pulmonary valvular stenosis is extremely rare. It's less than 10%. That's in a tetralogy. That actually is not tetralogy.
Yes,
No,
correct.
the infundibular plus valvular is the main stenosis in 75%. So just pulmonary balloon valvotomy, I don't think it will do anything for that. And the isolation of the infundibulum, that's absolutely hopeless. It will never work. I think it is disastrous. So I think the first two, then ductal stenting is good.
Yes, sir.
What are the types of ductors you see? Can you tell me the classic name? What the usual ductus shape? Usual ductus is a conical shape. It's got a dilated aortic end of the ductus and a cone-like thing to the plume. Sometimes it's a straight tube, and sometimes it is a kissing ductus that amounts to almost a AP window on the ductal side. Then there are maybe longer ductus with constrictions, and the most dangerous is sometimes a tortuous ductus and the vertical ductus coming from the undersurface of the aortica. So each one is different when you try to uh, do a stenting. So
Okay,
some
sir.
of them are not suitable for stenting at all. If it's suitable, of course, it's very good. Stenting is a good thing. And I think Sujit told you last
Yes,
time the
yes, sir.
advantages and disadvantages of a stenting versus a infundibular stenting.
Yes.
Sir.
So there are, you can compare both the BT shunt with the stenting. So
Yeah,
BT shunt, the morbidity and mortality is slightly higher in the initial
yeah,
period, initial peri-procedure period in comparison to ductal stenting. But overall, what you have seen is in the long term, if the shunt is done well,
yeah.
it's good. The BT shunt is much better compared to ductal stenting.
Mm.
In the PDS stenting, initially there's absolutely no post-op issues. The child flies out of the ICU very fast. It's a very short procedure. It is, you know. But in the long run, what tends to happen is the stent can sometimes impinge onto the ostia of either branch PS. So either the LPA or the RPA can get obstructed because of the stent if the stent protrudes into the pulmonary artery, into the main pulmonary artery. So, but there are, I mean, it can be done without all this, but the initial problem, mortality and morbidity is higher with a PT shunt compared
Okay,
to
sir.
a PDS stent.
Yes, sir.
Yeah, but so if we have the expertise for a PDS stent in the hospital, that is preferred now. But they cannot do it in all cases. They cannot do it in a very tortuous PDA like Sir said. They cannot do it in where the anatomy is not right. Okay, it cannot be done in all cases.
Yes, sir.
So if the anatomy is not right, it has to be done surgically. If the PDA is straightforward and can be stented, then that is the first choice,
Okay, sir.
at least as of now. So and also if once your PDA is stented, suppose the stent might in a position to deal with that also. Because stents can sometimes move, it can embolize, all that, anything can happen. Device
Okay.
can come into the MPA, it can go anywhere.
Yes, sir.
Okay, so in that situation, we'll have to take the child to OT, go put on bypass, remove that stent or whatever, and then do a shunt also. And sometimes what we have done is, if the stent is migrated or it's embolized, We have removed that and we have done an ICR also sometimes
Mhm.
Okay, sir.
because the branch waves are all right. So the only thing is the all these things are done to delay surgery so that the child grows bigger. The child, better are the outcomes. But in
Yes, sir.
emergency situations, when when uh, these things happen, then your plan changes according to the situation.
Okay, sir.
And there is another palliative procedure which was done way back, I think in 1950s 60s. I think Jared sir may remember. It's called the Brock's shunt. Brock's procedure is where we just do a primary RVOT infundibular patch, that's all. So we just like a just like a RVOT patch or like a tap transannular patch without closing the VSD.
Okay,
So
sir.
that is almost like doing a shunt, but in almost like an RVOT stent.
Yes, sir.
The
So yes, sir.
the original Brock shunt was done without bypass. You
Yes, sir.
open,
Yes, sir.
then sternotomy, then they have got a infundibular punch. You make a small bursting and
Yes,
then put a punch-like thing. Try to take out the part of the infundibulum and do a pulmonary valvotomy. Those
yes, sir.
results were not very good. But
Yes, sir.
what Devi Shetty says now as block shunt is actually in a patient who is not suitable for correction because of the uh, pulmonary arteries are very small. Such
Yes, sir.
cases, you have to select the cases. The pulmonary arteries are very small. You do open heart surgery. You make a small uh, tap, uh, transannular patch, and do some little bit of infundibular resection. I don't know why it's not very popular. It is very good because
Yes, sir.
there's a forward flow, and both pulmonary arteries and the main pulmonary arteries will dilate equally, not
Yes,
like
sir.
shunt, sometimes. But the only disadvantage is if you have not calculated the exact size of pulmonary arteries, then you may overdo that actually, because you are leaving the uh, BSD open. So that's a palliative. That's what now we call Brock's procedure. It's
Okay,
Yes,
sir.
sir.
it's
Yes, sir.
for selected cases. It may be all right when it's be severe pulmonary uh, obstruction at any level. Then they can do this operation. Leave VSD open, and then
Okay.
then the force from the RV ejection equally dilates the main pulmonary artery and both pulmonary arteries. I don't know whether anybody does it, Sujit, now.
No, no, sir. That's all. So the RVOT stent is somewhat like a Brock shunt, no, sir.
Yeah, yeah.
So since the RVOT stent is being done these days,
No, they don't do.
there is
Yeah,
no need for a Brock shunt because they can
they
just stent
they
open the
they.
RVOT.
Yeah, Devi used to do this. If you know,
Yes,
use.
sir. Yes, sir. Correct, sir.
Okay, sir.
Sir, I'll have to get to the hospital, sir. So I'll
Yeah.
just I'll
No.
leave the meeting.
Usually, how much do you
Yes.
wait after?
Okay, okay, Sujit, thank you.
Yes. Sure, sir. Sure,
Mhm.
sir. Thank you, sir. Thank you.
Thank you very much. Thanks.
Thank you. Thank you, sir.
Anything else, Krishna?
Not really, sir.
No, otherwise,
Uh,
then I was planning to ask them usual questions in exam.
yeah.
See, first question they ask is,
Yes, sir.
what is the incidence of tetralogy and what is the natural history?
Sir,
They always ask this question. You say that tetralogy is the most common cyanotic congenital heart disease. It's about 5 to 7% of all congenital heart diseases, and it's all this I just referred yesterday. It's all otherwise expressed as 5 to 7 for a 10,000 live births. are born with tetralogy of Fallot, and it's a 5 to 7 is the percentage. Some people, the Mayung Park quotes about 10%, but 5 to 7 is the incidence of tetralogy of Fallot. Okay. And what is the natural history of this? All you should know complete.
Yes, sir.
How many percentage of tetralogies are cyanotic at birth?
So,
And untreated, what is their natural history?
sir, sir, at birth, the degree of RVOT obstruction determine the symptoms, sir. If,
No, no, just tell me the percentage. How many kids with pathology at birth are cyanosed?
this
About two-thirds, 66 percentage of cyano patients with pathologies are not cyanosed at birth. Many
okay, sir.
people say, so that's why very often say it's a delayed onset of
Sir,
cyanosis, and that time Krishna and I described you why they are not cyanosed at birth, you know. You know that. Why they're
yes,
not
sir.
cyanosed at birth.
We discussed
I
this
told you.
last time.
Yeah,
Yes, sir. P- PDA, sir. Will
yeah, PDA. What happens to normally PDA?
be, uh, one is normally after birth it will close, and it will take around 6 weeks to fully obliterate the PDA, and there is a presence of fetal hemoglobin,
Yeah,
which is shift the oxygen curve to left side, sir, and
yeah. First PDA
when
normally normal kid has got a physiological closure by about 12 to 24 hours. It closes physiologically or functionally. And the
yes, sir.
anatomical closure takes about 2 weeks or something. But
Yes,
many
sir.
of these cases, congenital heart disease is delayed. That's why it may take longer time to close. So one reason why they are not very diagnosed is because of the presence of PDA.
Yes, sir.
Then you said fetal hemoglobin. We
Yes,
told
sir.
you that time the affinity, because in the placenta it collects the oxygen, its affinity is much more, you know. And
Yes, sir.
when is it changed into adult hemoglobin?
6 months, sir.
Six months, or you can say 6 to 12 months it changed.
Okay, sir.
Okay. And untreated, what happens to tetralogy?
Sir, the two-third are alive by first year, 1 year.
Yeah, yeah.
50% of the kid with untreated reach 3 year of age.
Very good, very good. And by 10
Uh,
years,
to 25%, 10 years,
uh,
sir, right,
yeah,
sir.
yeah, yeah. At 40 years, only 5%. Good, very good.
5%, and
Okay, okay.
10% at the in 20 year, 10 to 10%,
Perfect.
sir.
Yeah, excellent answer. I think that's what given in the cardiologist, Indian
Parlop,
cardiologist given in.
Parlop also.
Yeah. Then the most common question asked is, what about the heart failure in tetralogy? Because tetralogy doesn't produce heart failure. What are the conditions 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, where tetralogy leads to cardiac failure? Don't
So
tell me.
15% of patient goes into cardiac
That
failure.
I know. That I never heard anyway.
50%.
Well, fun fact, 15, sir, 15.
1-5. Okay.
Yeah.
What? Why?
What are the causes actually from the birth At the age of 5, 10, what are the causes of heart failure in tetralogy? This
One is
question they always ask.
with the tetralogy with the absent pulmonary valve,
Very good.
then
Absent
non-rest.
pulmonary valve syndrome is one cause because why do kids, they die at very young age? Why? How
Yes, sir.
do they die? They
Uh,
don't die of they don't die of cardiac failure or
compli
what happens
Fine.
in a absent pulmonary valve? The pulmonary arteries are hugely dilated.
Yes, sir.
They press on the trachea and the bronchial
From
tree, and so they produce atelectasis, pneumonia also. So they die of respiratory complications. But one of the earliest causes of heart failure is absent pulmonary valve syndrome. The
yes, sir.
absent pulmonary valve syndrome, about 30% may not have a PDA. Most of the pathologies will have a PDA. These kids may not. So one, okay. Then
When
other
with
causes of failure in the infancy.
TOF with infective endocarditis, severe AR
That
with
is,
the
that's much later comes.
in this
You know the
pulmonary
incidence of, the incidence of endocarditis in pathology.
less than 1%,
What I read is about
5%.
3.5% for 10,000 person a year or something now. So it's extremely rare. It comes later on. Much more common endocarditis comes after repair of pathology when you and later on you put a pulmonary valve, a bioprosthetic pulmonary valve, that may get endocarditis, or if you got a conduit, that may
Okay,
get injured. And the third cause is the aortic valve endocarditis. That may produce aortic regurgitation and cardiac failure again. But it should come low in the priority.
okay, sir.
The next
Anemia,
common is pulmonary atresia with MAPCAS.
plus yes, sir. Overriding.
Huh? Because what are the types of MAPCAS?
Uh, T type.
Type 1, type 2, type 3.
Is arising from bronchial
Good. Type
artery
1 is from bronchial arteries.
and then
Mainly from the descending thoracic aorta. Lot of MAPCAS arise from the descending thorax. And type 3,
from
I'm sure every
from
textbook says it.
from other like carotid artery, coronary artery.
Not carotid, subclavian artery, maybe
Yes, sir.
from the internal memory artery, maybe even from the coronary artery, or maybe from the celiac arteries. So this is type 1 from bronchial arteries, type 2 from the descending thoracic aorta, type 3 extra, like a
Extra.
subclavian, like internal memory artery, even from coronary artery they have described, or below the diaphragm. Okay,
Sir.
that, that you should know.
Yes, sir.
Then other causes of cardiac failure.
Then top with anemia, sir. With,
Very good. Yeah. That means a high output failure.
okay, sir.
What are the conditions of high output failure? Anemia,
Preg-
very good.
Pregnancy,
Good.
very, very
Very good. Only one more. Hyperthyroidism.
hyperthyroidism, sir.
These are the conditions where there is a high output failure. Okay. Then what else?
Cyanotic cardiomyopathy.
Very good. Very late stage, very good. Cyanotic cardiomyopathy because both the right and the left ventricle are chronically hypoxic and they can go into failure. Good.
Later on, top with hypertension.
Very good. Hypertension, left ventricular hypertrophy can lead to failure. They say later on ischemic cardiomyopathy, but that's
Okay,
very rare, but can be. Then they say one thing is HOCM,
okay, sir.
is HOCM, hypertrophic obstructive
Cardio.
cardiomyopathy, eh, along with very good.
Is that
And
common, sir? High hokum with the tetralogy because both the ventricles outflow are obstructed. Is that compatible with life?
pathology with a patient who develops HOCM, they go into severe failure and you have to treat them almost immediately. Then the other thing is post-surgical.
Okay, sir.
Post-surgical, we just now mentioned overdoing the shunt.
Yes.
Then uh, all patients with large transannular patch, they go into severe pulmonary regurgitation. And by you have to follow them up at least when they are 10 years old with a what's the best investigation for a RV dysfunction due to a large transannular patch.
Yeah. MRI, sir?
Yes, cardiac MRI. That's how it's designed. You know the indications for a pulmonary valve replacement in a transannular patch produced pulmonary regurgitation. What are the indications? This is some entity which is now known very much,
Yes, sir.
as
Sir, in,
all of you see that indications and management of a severe pulmonary regurgitation. The most important investigation is cardiac MRI. The most important thing is actually the right ventricular and diastolic volume, more than 160 ml per meter squared. Now they say 150, and the end systolic, I think 70 or something, ejection fraction 45, and you
correct.
refer all those things, and the
Yes, sir.
QRS complex more than
More than 180.
160 milliseconds. And now, of course, instead of 160, they say 150. Okay? You
Yes,
refer, I don't remember all of these things, but these are some of the criteria. The right ventricular end diastolic volume index
yes, sir.
and the systolic index and the ejection fraction of the right ventricle and the left ventricle and the QRS width of the QRS complex and there are so many things later. And what they do for these things,
Okay, sir.
what are they, what they do?
One
This
is
become a common thing now,
pulmonary valve stenting or pulmonary valve replacement, sir. With
What? How can a leaking thing you gone stenting? Pulmonary valve
with-
replacement. You
yes, sir.
cannot stent it. That's a gross mistake. You can do pulmonary valve replacement
In,
either by catheter or by surgery or by hybrid procedure. Okay?
Yes, sir.
Because you put, especially if you put a large patch,
Yes, sir.
it becomes so huge, the uh, not even the biggest valve you can put in there. So that's why surgical is done. If you put only small transannular patch and it's not too large, you can put a large bioprosthetic valve by a
Yes.
cath, or you can do it by a hybrid procedure. You open, sometimes if your pulmonary artery, the annulus is very large, you can constrict it by putting a tape around it or something so that you can have a shell.
Okay, sir.
And on to that, by hybrid procedure, you can deploy the valve.
Okay, sir.
So you should know these things actually.
Yes.
And what is the mortality of tetralogy of valve and what long time survival? These are the questions they ask in the exam.
Okay, sir.
So you should, yeah. In advanced centers, they say the mortality, 30-day mortality of tetralogy is 1%. I don't know. You look into our statistics also,
Okay, sir.
and it's an excellent operation properly done without transannular patch. The 20-year survival is about 90%. So it's a very good operation. So
Yes, sir.
you refer to these things and write down,
Yes, sir.
the surgical mortality, the survival 10 years, 20 years, and all these things, then you will be able to answer nicely in your exam. Examiner will be impressed if you quote this one, two, three, the causes heart failure. Sri Krishna knows our time is one of the most common questions. What are the causes of heart failure in tetralogy? Should be able to say one, two, three, four, like that.
Again, you must know the published
Yeah,
results as well
yeah,
as NH results.
and also.
Okay, sir.
Okay. Any doubt?
So in the last three classes, we have discussed tetralogy in
Yeah,
detail.
yeah,
Remember, you will always have a tetralogy case or a
yeah.
cyanotic case in your exam. So you must know everything about it.
Yes, sir. Okay,
And
sir.
and if you start off with the tetralogy and you answer all these things, the
Yeah.
other even if you make mistakes in the other cases, it will be pardoned off. You know.
Yes, sir.
So how you make an impression in your first case is what happens in the exam. So
And they will
know
ask
your
another, yeah, another thing they ask is about the reoperations for tetralogy other than valve replacement.
that is put on the slide, sir.
Yes, sir.
Yeah, okay.
Indication wise, sir, Kirkland says like redo for severe PR, residual or recurrent RVOT obstruction. Then if any residual VHD is there,
Uh,
severe.
what is the residual obstruction? How much?
Uh,
Your gradient or the
Or the peak
PRV,
RV
PL.
duration? Yeah. It's almost we said last time, ideally it's 0.7, the RV LV pressure ratio. It's the same for if it is a post-operatively, you have to reoperate on them. And the shunt, if the shunt is more than 1.5 is to 1, that's a significant shunt.
Yes,
Because
sir.
now you have taken away the obstruction. The shunt produces a lot of flow into the resistance is not there. So if the shunt is more than 1.5, some people close it with a cat closure, provided the residual VSD is in the lower part of the patch. Okay. Tricuspid regurgitation. Oh, yeah. Arrhythmias, because right ventricular arrhythmias are very common, no?
Yes, sir.
Then atrial fibrillation is common.
Yes.
Aneurysm, the RVOT, it's usually a pseudo aneurysm or a true aneurysm. Okay? Of the
Yes, sir. Yes.
patch. Okay. Any other slide?
No, no, sir.
So this, I think this much you'll know. If you answer that, I think you'll easily pass.
Okay. All right, sir. Thank you.
Thank you.
I
Thank you
think
very much.
we will
Thank you,
stop
sir.
there. Yeah. Thanks, Hitesh. Fine.
Bye. Bye.